Excellent. Well, thank you for joining us for this presentation, Dr. Rauchman. He is a nephrologist at the Washington University at St. Louis and also specializes in pediatric to adult transitional care, which I know is an issue that's also relevant to our community, as many of the children that we're aware of are getting older and moving into adulthood. So we're very grateful to have you here to talk to us about kidney and urinary related challenges in neurodevelopmental and genetic disorders. Thank you, Dr. Rauchman.
Thank you. So I'm going to share my screen, and which I hope you can all see, correct? And is my volume high enough?
Looks and sounds good.
Yeah. Okay. So let me go to slideshow. Okay. So first of all, I want to thank Foundation for the opportunity to speak, and in particular thank the families who have joined to listen. So the next 20 or 25 minutes, I'm going to talk about congenital anomalies of the kidney and urinary tract, but I'll start with just some basics about the kidney. I'll touch on what are manifestations of kidney disease, and then a little bit on how we investigate kidney disease and how I got interested in ASXL related disorders. And although there'll be time at the end for questions, I want people to feel free to stop and interrupt if some of the information is you have a question, so that as we proceed through the discussion, you don't feel like you were lost on something that I said. So without further ado, I will continue. So as was mentioned, I'm a physician scientist, which means that I see patients. I see patients with chronic kidney disease, adults, but I also have a transition clinic for pediatric to adult care. And then I have a research lab where I investigate these disorders. So I will start off by giving a sort of a very brief introduction to how the kidney works and get us all up to speed. So the kidney is comprised of a bunch of functional units. So if you take a slice of the kidney, right, and you look at it under a microscope, and this is a schematic, of course, there are these functional units. They're called nephrons, and there are about 500,000 or more in each of our kidneys of these microscopic units. And so they basically are comprised of a filter called the glomerulus. So the glomerulus filters the blood and allows some things to be excluded, like large proteins normally are excluded, but other things get into the urine. And these different segments of the nephron each have specialized functions to regulate a variety of homeostatic functions in the body, which I'll go into in a minute. For the purposes of developmental disorders, nephron number is fixed at birth. So you make your nephrons, during embryonic development, and at birth, you stop making new nephrons. So you can imagine that if a baby, for example, is born prematurely, which can happen for a lot of reasons, including related to syndromes, I think, like ASXL-related disorders, they will not have made the normal number of nephrons, and that in and of itself can be a risk factor for chronic kidney disease later in life, particularly because as we age, we lose nephrons. And so the kidney filters a lot of blood, 200 liters every day. And again, each of these segments take that blood and take components of the blood and regulate a variety of physiological functions. So what are these functions? So just water balance. The kidney has to know, sense, or the body has to sense, actually the brain senses, whether we need to hold on to water or get rid of some water. Electrolytes in the blood, so the major electrolyte circulating in the blood, sodium, or in our cells, potassium, minerals that are important for bone growth, and a variety of other physiological functions are regulated by the kidney. Acid-base balance. So if when we eat a meat diet, we generate a lot of acid, and the kidney has to be able to get rid of this excess acid and hold on to the base to maintain these functions, because if it's not properly maintained, our proteins in our bodies can't function properly. The volume of our blood is regulated by the kidney, and the kidney is really probably the most central organ in regulating blood pressure, and many kidney diseases lead to elevated blood pressure or hypertension. So the kidney has these important excretory functions. So as I alluded to, there are a lot of metabolic waste products that get generated in addition to the acid as a consequence of just normal metabolism for eating and generating energy in the body. Drugs that we take, many of them are either directly excreted by the kidney or they're metabolites, so they get acted on by other organs in the body like the liver, but they're still, these chemicals have to be removed. And even just natural hormones that our body makes are often excreted in the urine. So the kidney has an important role there. And then kidney also, just like with drugs, which are essentially foreign chemicals, but things that you might get exposed to can be handled by the kidney as well. And then finally, the kidney does have what we call endocrine functions. So endocrine glands are glands where the organ makes something like insulin, for instance, which is made by your pancreas, but it goes to other organs and cells in your body, right, to regulate functions. The kidney makes a few hormones as well. So a key hormone it makes is called erythropoietin, which stimulates the bone marrow. It's the main hormone that stimulates your bone marrow to make red blood cells. The active form of vitamin D requires the action of cells in the kidney. And then these hormones in a system called renin-angiotensin, which are a key regulator of blood pressure, are also made in the kidney as well as in other organs. So getting to the condition that we're going to talk about, which are congenital anomalies of the kidney and urinary tract, which go by this acronym called CACUT. These are not actually rare disorders in aggregate. They occur anywhere from 3 to 6 per 1,000 live births. Most of them are what we call sporadic. That is to say, they're not part of syndromes, but there are many congenital anomaly syndromes that affect different organs in the body that also include defects in the kidney. These disorders are the most common cause of childhood kidney failure. And it's also important to note that not only are they an important cause of childhood kidney failure, but that children who get these disorders also often go on into adulthood with a developing end-stage kidney disease. And then even when there are no other associated anomalies, just by virtue of having chronic kidney disease, when it gets moderately or severe or advanced, can lead to important implications for children, in particular, growth retardation, developmental delay, so just neurodevelopmental delay, even if brain formation is normal, anemia, bone disorders, and heart disease. And then, as I alluded to earlier, subtle changes in the number of these functional units, which are hard even to detect clinically sometimes, are associated with an increased risk of high blood pressure and chronic kidney disease later on in adulthood. So I'm going to take a few minutes to go through this slide, which illustrates the range of the more common types of congenital anomalies of the kidney and urinary tract. And so what you see here are these schematics. And then these pictures here are ultrasounds of the kidney or bladder to show you clinically, when we look at these things, when we're testing for them, what they look like. So these sort of fall into two classes. You have examples where the actual kidney is not completely forming properly. And then you have other instances where there's blockage to the flow of urine. And so here's an example of what we call renal hypoplasia. That is to say, one kidney is much smaller than the other. So you can imagine that if you normally have these 500,000 filtering units in each kidney, so a total of 1 million, that in this individual, there really might only be 700,000 total, maybe less. And you can have more severe examples. So for example, you could be born with only one kidney, so this other kidney didn't form. You can be born with 2 small kidneys, but this gives you an idea of the range of what we call hypoplasia or small kidneys. Sometimes the kidney not only does not form the proper number of filtering units, but those filtering units that do form are not normal. They are what we call dysplastic, or in many cases, they can form cystic structures. So a lot of the filtering units that are there are not functioning normally, even though the number may not be as dramatically reduced. And then these connections between the kidney and the bladder, so the ureter connecting the kidney and the bladder, can have a variety of problems. Here's an example where you make 2 of these collecting tubes, the ureter between the kidney and bladder, and those connections don't always happen normally, and they can cause problems in terms of the flow of urine that can ultimately damage the kidney. So on the other side here, and so just to go back to there, you can see here's the kidney outlined here on the ultrasound. It's smaller than normal. These fluid-filled structures that I'm pointing to here are the cysts in the kidney. And this is a kidney that we would call hydronephrotic, which means to say the back pressure is causing fluid to accumulate within the kidney itself. So on the right here, you have some of these, what we call obstructive disorders. So vesicoureteral reflux is a very, very common disorder. And what this involves is that where the ureter, I'm showing here, and I think you can see my pointer, correct? Where the ureter is entering the bladder, there's a particular mechanism there. It's called an anti-reflux mechanism. So when the urine leaves the kidney, it goes down this tube, the ureter, and it goes into your bladder. And the bladder is storing the urine, because otherwise you would be constantly going to the bathroom if you didn't have a storage compartment. But what the anti-reflux mechanism does is it makes sure that the urine that's stored in here, as the bladder gets distended and the pressure increases, that the urine doesn't reflux back into the kidney. So when this mechanism is not properly formed, you get reflux into the kidney. That back pressure causes this tube to get bigger, to dilate. And as a consequence, the back pressure damages the kidney and predisposes to infections. On the other end, where the ureter connects into the bladder, okay, you have a junction between a structure called the pelvis and the ureter, and there can be a blockage there as well. And similarly, it can cause back pressure and damage. So like here, you see these dilated fluid-filled structures within the kidney, and ultimately that back pressure destroys the kidney tissue here. So you lose these filtering units. And then the final one that I'll point out is something called posterior urethral valves. So these are in the urethra, so that's now when the urine leaves the bladder and goes through the penis or through the vagina and it is excreted, you can get these structures that form, and this is pretty much exclusive, this is exclusively occurring in males, that block the flow of urine out of the bladder. But similar to all of these other conditions, the back pressure can damage the kidneys. So the bottom line is, in all of these cases, you're losing functional units of the kidney, and so kidney function can decline. So mutations in genes that regulate the development of the kidney during embryogenesis in the fetus are a very common cause of these conditions we call CACT. There are some maternal factors that I'm listing here that are also risk factors for some of these conditions. And as I also mentioned, during gestation, if there's hypoxia to the fetus, if there's prematurity, if the fetus is not growing properly, the kidney will not form the proper number of functioning units. And this in and of itself, even without any genetic problem, can predispose to chronic kidney disease later in life. So to date, we know there are about 40 cases of monogenic causes of congenital anomalies of the kidney. Monogenic meaning a single gene is mutated and is responsible for that problem, just like ASXL mutations can cause these syndromes as a single gene syndrome. But it only accounts for maybe 15 or 20% of cases. So there are a lot of genes yet to be discovered that cause these anomalies of the kidney. And there are many syndromes like Bainbridge-Roper or the other ASXL-related conditions that have kidney anomalies or bladder anomalies as a feature or a part of their syndrome. And many of these disorders have been modeled or can be modeled in mice to study them further. About 180 mouse models with congenital anomalies of the kidney have been described, some of which we ourselves have created. So a little bit about what chronic kidney disease is. So the way we sort of define it in simple terms is that it's a reduced ability to filter the blood. So remember I said that the nephron has a filter, which we call the glomerulus, and we call this filtration function glomerular filtration rate, or it gets abbreviated as GFR, and we measure its decline as a reflection of reduced kidney function. So a key point I want to leave you with today is that kidney disease, and this is often asymptomatic until the very late stages. So it can be a very, very silent disease. In its very late stages, you begin to see manifestations that reflect disruption of these homeostatic and excretory and endocrine functions that I mentioned. But that doesn't happen till very, very late. And then there can be some disease-specific manifestations. So for example, I mentioned this problem where there's refluxing of urine. So individuals who have this condition often have recurrent urinary tract infections, which is, unique to this kind of a problem, but may not occur with, a child that has a small kidney or is missing one kidney. So how do we assess function of the kidney? Well, we measure markers in the blood that reflect how well the kidney is filtering. So the most common one we use is creatinine, but as I'll discuss at the end, it's not a perfect marker, particularly for a number of the cases that we see where children have developmental disorders. And another one, a newer one we use is called cystatin C. So a normal glomerular filtration is greater than 90 milliliters per minute. But the other way we know that there can be kidney disease is there's protein, so albumin, which is the most abundant circulating protein in the circulation and is normally only present in very small amounts in the urine. It starts to leak into the urine because this filter, this glomerulus, when it gets diseased, gets leaky. And then if the tubes that are supposed to act on this filtrate that comes through the glomerulus are not working properly, even before there's a marked reduction in kidney function, you can start to see problems with blood chemistries already, even at an earlier stage. So what are the kinds of things that we ask our patients who have kidney disease? So as I mentioned, early and mid stages, there are no symptoms. And unfortunately, kidney disease is often silent for a long time and can go undetected. But certain diseases, so for example, if there's a lot of protein in the urine, even when the filtration function is normal, patients tend to accumulate fluid and they get a lot of swelling. Or as I said, if the tubules have a particular problem, the chemistries can be very abnormal. So that the potassium may be very high or it may be very low, for instance, even though the overall filtering function is working fine, but a specific segment of the kidney is not able to do its job properly. But then as the kidney disease progresses and gets fairly advanced, we ask a lot of questions that I've listed here, because these are the things that tell us that the individual is getting to the point where they may need dialysis. Now, for the parents here, I'm sure you're looking at this and you're saying, well, you know, how does this work for children who have more severe neurodevelopmental disorders? And that is a huge, huge challenge. When I see patients in my pediatric transition clinic, some of whom have severe neurodevelopmental delay, I rely very much on the parents to tell me, and they are very keen observers of whether the behavior of their child or their young adult is changed. But it can be a big challenge to figure out when they're becoming symptomatic from their chronic kidney disease. There are some, I see a lot of adults because I'm not a pediatrician by training, but I know from my pediatric transition clinic that there are unique challenges in children with kidney disease. So the care has to be age appropriate. There's a big difference between treating an infant and treating a teen. The measures of kidney function are not as well standardized in very young children. And in particular, as I'll show at the end, in children or young adults who have severe congenital anomalies that affect many organs, and they may have very low muscle mass, and that can affect the measurements that we do to assess their kidney function. Growth is a huge problem in children with chronic kidney disease here in growth curves. These children, what we say is they fall off the growth curves. They don't continue to grow. Their weight doesn't continue to increase when they have chronic kidney disease. Some of them end up going on growth hormone. Even in the absence of other problems, they can have developmental delay as a consequence of their kidney disease, and sexual development can also be impacted. So it really has broad implications for the children who have chronic kidney disease. And then a big part of what happens systematically from kidney disease is effects on the heart. So we know, for example, in adults with chronic kidney disease, the most common serious complications and causes of death relate to heart disease. And certainly even in children who have advanced chronic kidney disease, heart disease becomes a problem. There's high blood pressure. The heart muscle gets thickened, called this left ventricular hypertrophy. They can get congestive heart failure with congestion due to fluid in the lungs. Their lipids become abnormal, putting them at risk for heart attacks. And unique to advanced chronic kidney disease is a risk of sudden death due to arrhythmias. One of the reasons they get arrhythmias have to do with abnormalities of things in the blood, like potassium, which when it gets very, very high can cause disturbances in the electrocardiogram, which lead to life-threatening arrhythmias. But there can also be other effects on the electrolytes related to the things that I mentioned. And so there are some treatments. So we have medications that can slow the progression of chronic kidney disease by reducing protein in the urine, very, very, very strict control of blood pressure. We can give back the hormone to treat anemia when it's severe. We have medicines to control accumulation of fluid, to help control the potassium level and the acid accumulation. We do things to treat the bone and mineral disorders, to promote the growth of the child and to prevent fractures. And in some cases, when available, there are more disease-specific treatments. So to end off, I'm just going to talk about, how do we identify some novel genes that cause these anomalies? Because as I said, many of them are yet to be discovered. So there are some challenges here. These disorders have variable expressivity and incomplete penetrance. So what does that mean? It means that the same gene, when mutated, can have different manifestations. You may have a child who has a small kidney, another child with the same mutation who has this reflux problem, because these genes can act in the same place, but it act in different places in the urinary tract, but also the way the kidney forms during development is such that when things go awry, they can go awry in different ways. And then the penetrance is incomplete. That is to say, you can have a mutation, which in one case causes a kidney problem, but in another case, in another individual doesn't. The other challenge is these are de novo mutations, meaning that we can't construct pedigrees because they happen just in that individual, and they're very rare. So when you discover one case, it's not sufficient for you to conclude that that's really the cause. And then you need to start to find other cases and do functional studies in animal models to try and validate whether the mutation is really causing these defects. And finally, as I said, many of them are clinically silent, so they go undetected. So this is an illustration of how we can look at the kidney developing in the mouse. So the kidney has a bunch of branching tubes. So in mice, we can make the mouse kidney fluorescent, and we can watch it grow, and we can create mutations in mice and see how the kidney development is disrupted. So these are the end part of that functional unit called the nephron, the very end of it. And then if we look at the beginning of that nephron, we can also look at that and how it grows. So the red are those branching tubules, and the white are these stem cells or progenitor cells that are growing and developing. And as you see here, the tubules are beginning to form. So those actual segments that work after the blood is filtered are forming tubules here, okay, from these white progenitor or stem cells. So another way that we're going about trying to discover novel genes that cause CACUT is to recruit families, specifically when a pregnant mom has a prenatal ultrasound and they're found to have a child fetus that has severe anomalies of the kidney. They're consented, and we recruit them into this study from this a maternal fetal care unit, and we sequence both the parents and the affected fetus or the child. And so in doing that, here's an example of some of our results. We uncovered this case that had a typical Bainbridge-Roper mutation. And this child had what we call unilateral renal agenesis. That is to say, one kidney formed, but the second kidney never formed. So the child was missing one kidney, and the child also had some cardiac defects, which were relatively mild. So I probably don't have to tell this group that ASXL-3 is a component of this complex called polycomb. And so when we find a mutation like this, we want to know, is it likely disease causing? Well, that's when I got in touch with Dr. Russell, who looked at this mutation and said, yeah, this is a typical Bainbridge-Roper mutation. But then we need other things to help us determine, was this just by chance? Could there be some other reason why this child was missing one kidney? Or is it really related to the ASXL3 mutation? So we want to do things to validate it. So one thing we do is we look, well, is there biological plausibility here? So this gene ASXL3 is expressed in the developing kidney in these progenitor stem cells. So it's at least present in the developing kidney at a point where it could cause a defect. We know from studying mouse models that other components of this complex, when they're defective, cause CACUT or cause hypoplasia of the kidney. And then finally, ideally, what we want to do is now go out and look and see, are there other cases where patients, children who have ASXL3 mutations that cause Bainbridge-Roper, do they have some of these same manifestations? And in the future, in the near future, I'm hoping to send out a survey to families to see if there are children out there who have been discovered to have anomalies of the kidney or urinary tract in the course of their evaluation for Bainbridge-Roper. So I want to end with a case I always, even when I give a pure research talk, I always try and bring a case in to really ground it back and because that's really the reason why we're doing this work in the first place is to help patients. And this is a case, one of the first cases that I saw in my pediatric transition clinic. So this was a 38-year-old female with Rett syndrome who was referred to me for evaluation of a small kidney. So this patient had a history of severe neurodevelopmental delay due to Rett syndrome. So this is a disorder that's usually caused by mutations in an X-linked gene that I've noted here. The patient had a history of seizures and scoliosis. She had to have surgery for her scoliosis. There was no known history of kidney disease. So in May of 2018, she had an ultrasound done of her abdomen. And the reason for the ultrasound was because she had nausea and abdominal pain. But the study showed that she had a very small, likely non-functioning right kidney. She had a stone in the kidney, in the left ureter actually, that was blocking the flow of urine. And it required that she have a surgical procedure to remove the stone done by a urologist. And at the time, her laboratory studies showed that her serum creatinine, so this measure of her kidney function, the filtration rate, was in the normal, well within the normal range. So she came to me and we proceeded with an evaluation. So the calculated filtration rate based on her creatinine was normal, it was greater than 90. But again, as I mentioned, so creatinine is made by our muscles and it's a marker of kidney function, just a marker. She has, of course, very reduced muscle mass. She's wheelchair bound. So the marker is not accurate. So using another marker, I was able to show that she actually had a reduction in kidney function, was down to more like 65 to 70. The next thing I did was I thought that since small kidneys are prone to scarring, which can lead to leakage of protein in the urine, we found then that the patient actually did have an increased amount of protein in the urine, 750 milligrams per 24 hours, normal being less than 150. So I started the patient on a medicine called lisinopril. This reduce her protein in the urine and control her blood pressure. And at the last visit this past August, the urine protein was down to a normal range and her blood pressure was very well controlled. She's receiving medication to reduce the risk of having more kidney stones. She's receiving treatment for her reduced bone density to prevent fractures because in 2021, she already had a fracture of her tibia. So I think this case illustrates some really important points that I want to leave you with. The first one is that this kidney disease can be silent, and untreated kidney disease with reduced kidney function and elevated protein can just exist as it did in this patient for decades and went unnoticed until something else happened. There are some treatments, some generic treatments that we have for chronic kidney disease that can help slow the progression, that reduce the protein in the urine to control the blood pressure. Kidney complications, when you look up descriptions of Rett syndrome, are not described as a feature of Rett syndrome. But there are mouse models of Rett syndrome, and those mice who have same mutations in the same gene do have some defects in the kidney and the urinary tract. So in a way, it wasn't surprising to me when I discovered that this individual, this patient, had some chronic kidney disease, and that people who have been researching Rett syndrome and doing mechanistic studies ultimately have come up with a drug. It's not a cure-all by any means, but there is an FDA-approved drug now for treating Rett syndrome, and I believe there's at least one other or maybe two others, Dr. Russell may know more, but that are under investigation. So it illustrates, the point that if we don't look for some of these things, we don't find them, and that by studying them, we may be able to reduce the progression of kidney disease when we discover it, and also research could lead us to discover some drugs that are specific treatments for particular syndromes. So I'm going to stop there and stop sharing and be happy to take any questions.
Thank you. That was an incredible presentation. I learned a lot, and I bet everybody else did too. And I see Laura has come on camera, so that must mean Laura has a question. So why don't you kick us off, Laura?
Laura Bedmaev. I'm the chair and founder of our foundation, and just absolutely thrilled to have you here. So thank you so much for all this information. My son Alex has 4-inch opitz. It's ASXL-1 and early stage chronic kidney disease. And as you mentioned, I believe that there are many undiagnosed cases in our community. Alex had gone for quarterly ultrasounds because Wilms tumor was something that we were monitoring for, and other potential cancers, and everything looked normal. Blood work was always normal. It wasn't until he had an orthopedic surgery and he had an inpatient stay where he was immobilized for some period of time, retaining urine, and urology said, let's have some follow-up tests. And they did urodynamic study, BCUG, DMSA, and that's how they discovered that he has this early stage chronic kidney disease. I think there's a lot of children who have neurogenic bladders, urinary retention. Alex has like grade 4 reflux, right? And, I think what I find challenging in general is like, there's, many kids have all these different abnormal organs, abnormal bones, right? And, each specialty looks at different potential surgeries they can do, right? Can we do it? Like there's a whole bunch of kids who have the reflux surgery, for example, right? But the brain is pretty powerful. And so like, for example, in the orthopedic context, they may try to make some change, but then like surgically, and then, a year or so later, the child is able to like reverse to how it was before with their body orientation, right? And so, I guess in terms of treatments, like one of the things that I'm trying to understand is, to me, ultimately, all of these things are neurological, right? And no matter how much we try to change, it's going to keep going in this other direction. So are there any like collaborations or explorations as it relates to like nephrology and neurology and how this kind of works together in terms of ultimately treating the root cause of this problem?
Yeah. So it's a great question. So to go to the case that I presented, the Rett syndrome, when you look at the animal models and you look at the patients, you're correct, I think, in saying that. So we don't know. So the possibilities are that you can have a gene, right, that like ASXL3, for example, or even ASXL1, which is also in the kidney, and that gene can have a role in brain development. But because it's part of this complex, which is expressed in many cells in the body and broadly regulates a lot of genes, it can also have a function in the kidney. So in that case, the brain is not causing the kidney problem. On the other hand, in the case of Rett syndrome, which I presented that case, my suspicion is that it is actually a neurological problem, whether it's from the brain or whether it's the nerves that directly innervate the ureter and the bladder are causing this problem. And it can often, it can be hard to dissect that out, but I agree with you. But I think in the end of the day, whether it's the first mechanism or the second mechanism, the consequence for the child is the same. So I think that it behooves us to look for these things early and try and because earlier intervention we don't have cures necessarily, but we certainly have ways of preventing complications. I mean, these children go through enough procedures that if you can prevent complications, and you can also prevent the development or at least slow the progression of the chronic kidney disease. So I think it's important. Now, having said that, I also understand that when you have a child that has so many problems, right, that the specialists really try and focus on the things that are the most important, and I get that. But to your point, just last week we had a guest speaker who is an expert in genetics of autism, and she and I are going to have a meeting because she has a whole large database, and I'm interested in seeing of those genes that cause autism, a number of them, like the ASXL genes, there are at least a few other cases that we're studying, cause defects in the kidney. And my suspicion is that in those cases, we're also missing some of these disorders. Yeah.
Thank you.
Mm-hmm.
Thank you. Jen, do you want to ask your question? Go ahead, Jen.
I think she may be muted.
Oh, you're on mute here. Let's jump to Julie Lopez, and then we can come back to Jen once Jen can unmute. Go ahead, Julie.
So my question is, we're good friends with Laura, and so we have had the cysteine C checked, and we've had different things. We've gone to the nephrologist before, and they've never found anything. But one of the things that concerns me is that, so for a while, to control seizures, we had her on a low version of the ketogenic diet. It was like one of the lesser, they kind of step you up, right? So it was on the very, very lowest version of it. And her organic acids were off the chart. They were just like in her urine, they were to the point where they said that if her pancreas, that they're as high as they could get with a working pancreas. And so that concerns me. Like, so I guess I'm wondering, should I be, and then she's also broken her femur 4 times. So different, one of them twice and the other one, and then up by her hip. And so my question is this something that you would recommend that I follow up more? The doctors, when I talked to them about it, they said, well, we've run the tests. In fact, when we talked to them about the cysteine C, they actually weren't very familiar with that. Obviously we've done the screening for Wilms tumors. So they've looked at the kidneys physically and they haven't seen anything. And so I guess I'm wondering at this point, it is something we're concerned about, but I don't know how, like, what else to do. Or is that something we should be concerned about, or should we just follow it? I don't know.
Well, one question I have for you is, so the reason that you were sent to the nephrologist in the first place, what was the trigger? What was the thing that your other doctors found that was worrisome to them?
So she had, I'm trying to remember, sorry, we've had so many medical things happen, but her kidneys, they decided it was the ibuprofen that she had been taken. They had some markers, I can't remember whether it was in the blood or in the urine. And when we went to the nephrologist, they were gone. And so they decided that she had been on ibuprofen for things. So. Yeah.
So, it may be that her creatinine went up a little bit on ibuprofen, which can certainly happen, and which is not specifically related to anything about ASXL 1, 2, or 3. I mean, that can happen to anyone. So
absolutely,
that's a possibility. I'm not an expert on ketogenic diets. What I will say is that, yes, those acids get excreted in the urine. That's how they get removed. In and of itself, I'm not aware of any evidence that their presence is damaging to the kidney. There are clearly conditions, metabolic disorders, where certain organic acids accumulate in the kidney. Give you an example: propionic acid. There's an inherited disorder. I follow a patient in the clinic with that, and those metabolites damage the kidney. We don't really know why, but they do. And in fact, there are physicians, nephrologists, who are treating obese patients who have chronic kidney disease with ketogenic diets. It's an experimental thing, but to my knowledge, so the point of that is that, to my knowledge, ketogenic diet per se is not damaging to the kidney. And the kidney's doing its job by excreting the organic acids. To just in the last point I'll make is with regard to the testing with creatinine and cystatin C and so on. So we know that creatinine comes from the muscle, and many of these children have low muscle mass. So it becomes a very unreliable marker. And so typically, I will measure cystatin C because it comes from many other cells in the body. And sometimes there's a huge discrepancy. So you can see that the function is low, right? And so doing that, measuring the cystatin C is probably a good way to determine the function in the absence when creatinine is not reliable. Having said that, we're only beginning to collect information about cystatin C. Just like things can make creatinine unreliable, I suspect there are things that make cystatin C unreliable. And so if I really not certain about what the function of the kidney is, there are other tests that are reliable. For example, something called iothalamate clearance, which is a nuclear medicine test, which measures kidney function. And I send a number of the young adults that I see for this test because I just need to know, particularly when their disease is more advanced, am I dealing with kidney function that's at 25% or 45%? Because the variation can be that much. Doesn't sound like in your case that's, for your child that's necessary, but just to give you a picture that there are ways to try and get at what the kidney function really is.
Would it be reasonable to ask for just to test for protein in the urine? Because that sounds like that's what you did with the other patient.
Yeah. So the reason I tested it in this particular patient is because when the number of filtering units is markedly reduced, the kidney gets scarred and it leaks protein. But if your child has had a urine analysis done,
then they've tested for that.
And then if there's significant protein, they would have detected that in the urine.
Okay, thank you.
Sure.
Thank you. All right, Jen, you want to try to ask your question here?
Can you hear me now?
Yes, go ahead.
Great. So I have a son with Bainbridge-Roper syndrome, and when he was born, he had a slightly enlarged lymph node on his neck, and they referred us for a kidney ultrasound. I believe the reason was because, actually, I don't even remember. I think it was because they said the cells that create those lymph nodes also have something to do with the kidney. When we got the ultrasound done, structurally, everything was fine, and we moved on with life. Now he's 6 and we are potty training, and we're finding that he voids a lot throughout the day, like many times, little amounts. When he has a full void, you can see that it's not consistent. It's start, stop, start, stop, start, stop, even though the volume ends up being quite a lot. I'm trying to figure out if it's a urinary system issue or it's more of a motor plan with the brain connecting with the muscle control of being able to urinate. So I guess my question is more about testing. Is there a type of ultrasound that can be done that's not necessarily to look at the structure of the urinary system, but more so like as you're drinking liquid and it goes down from the kidney to the bladder and empties, to watch the function of the system versus the structure of the system?
Yeah, again, this is really in the area of, I would say, a pediatric urologist, but yes, there are ways to look at, just simple things like, is there urine retention? They can scan the bladder. Is the bladder not being emptied properly? There are studies that can look at whether there's reflux of urine. There are studies that can look at if the bladder, what we call urodynamic studies, where they fill up the bladder and then they can look at how the bladder is contracting. I mean, it sounds like this is a problem of bladder function, but there are other possibilities. If the urethra had a stricture or was not normal, but it sounds very much along the lines of a lower urinary tract problem. And I think a pediatric urologist is certainly very capable of trying to sort it out. And I know, with a number of these kids who have these problems, they have to go through some training to have voiding schedules and, and so on, to try and help them empty their bladder on their own as much as possible, in an effort to avoid self-catheterization, if that's what's needed. But I think a pediatric urologist definitely have things in their armamentarium to try and sort through this kind of a problem for sure.
Okay, great. Thank you so much.
Thank you. All right, I have a question from the chat. It says, I'm a parent of a young adult with ASXL1 syndrome, so Boring-Opitz syndrome, who had stage 5 Wilms tumor. She lives with 3/4 of one kidney. We are also transitioning from pediatric to adult care. Do you have any advice for me as a parent when looking for a nephrologist and tests that we should request?
Okay. Yeah, so in terms of transitioning, I think increasingly, but still a minority of centers, academic centers, have transition clinics. So I don't know where you live, and if there is a center, an academic medical center, you could inquire as to whether there's actually a pediatric transition clinic. And I mean, the way I run the clinic, or the way I do it, is I have close contact with the pediatric nephrologist, so and the hospitals are next to each other. I meet the family and the child with the pediatric nephrologist. That's how I get introduced to them. So they're given advance warning. We're preparing you for the transition, and usually the next visit is with me. But if the family and the child are not ready for that, then they might see the pediatric nephrologist 1 or 2 more times. And really, when they're ready, they come in and see me. And so that's, if there's such an opportunity to have that kind of a setup where you are, I would recommend that. And then the other thing I will say, which is important, and why, depending on the nature of your child's problems, why I think that's important, is for certain specialties like neurology, particularly with neurodevelopmental disorders, my impression is that there is not pediatric to adult transition for the neurologists. The neurologists continue to follow these individuals even when they're older than 18. So having this night, and then if there's Wilms tumor, it may be that although the child is now a young adult, that the expertise is with the pediatric oncologist. And so having that close connection, I think, is important. And I spend a lot of time in contact with the pediatric doctors, in particular the pediatric neurologists and the neurologists who are continuing to follow these children, even though I'm an adult nephrologist seeing them. If that is not available, then you'd really have to try and see if there may be, even though it's not an official pediatric to adult transition clinic, if there is an academic medical center, there may be one provider or 2 providers that sort of take on most of these patients because they have an interest in it, and because not every provider wants to take on the case, to be honest with you. I don't know if that answers your question.
Great. Thank you. And so that brings us to the end of our time. I want to thank Dr. Rauchman for presenting. This was an incredible talk. This will be a great addition to our resource library to make other families aware of a lot of what you've talked about and described. There was one question in the chat that we didn't get to about what tests that families should advocate for if they have concerns. So we can gather that answer by email and share it with everybody who is registered for today's meeting. And also want to encourage you, if you are not already enrolled in the ASXL registry at UCLA, this is the place where we try to do as much of the research as we can to concentrate it there. This is run by Dr. Bianca Russell, who's an expert in all 3 ASXL-related disorders. The email there is on the screen to enroll. You can also find more information on the Our Foundation website, ourfoundation.org/research. And participating in surveys like this is how we get information out of webinars like this and discussions and get it into the medical literature. So you and your doctors and the doctors of newly diagnosed families can find out what these trends and common symptoms and complications are and how best to manage them to help make sure your kids are healthy. So thank you again for being here, everybody. We really appreciate it, and are really looking forward to this continued collaboration between Dr. Rauchman and the UCLA team, and continuing to build our knowledge about kidney and urinary related challenges. Thank you so much.